Started. I think we have about 60 people in the meeting right now, and I expect people to slowly drop in the coming minutes. So I would like to welcome all of you to this webinar with Dr. Pejman, who is going to talk to us about understanding mechanisms of change in ISTDP. I'm Thomas Eslov, and we here at the Malmö Center for ISTDP are very happy to have you all joining us from all around the world to listen to Dr. Pejman.
One of the most tumultuous times in Credit Suisse's 166-year history. His promise was completely intact as you have these two mega scandals. But from a financial point of view, was
please mute everyone and just open speakers.
Yeah. Give me 1 sec. I'm muting everyone. Thank you, Harald. All right. Please, so here's the structure for today. We have about a 30-40 minute presentation by Dr. Pejman now, and then we'll have time for some discussion. And if you have questions during the presentation, you can type them in the chat, and depending on how big they are, I will let them through to the doctor. Please, go ahead. Thank you.
Wonderful. Thank you very much, Thomas. Before I start, may I kindly ask you whether it's possible to record this meeting if we haven't already started doing that?
Yes, we are recording it.
Wonderful. That sounds great. Hello, everyone. Thank you very much for attending. My name is Pejman Hoviatdoost. I am going to speak to you today about my recent PhD that I just very recently finalized on understanding mechanisms of change of intensive short-term dynamic psychotherapy. I would like to thank Thomas for organizing this whole meeting and every single one of you for attending. Just to kind of speak about some of the rules here, please feel free to type any questions as you have throughout the talk. And Thomas, please feel free to let me know as anyone asks a question. I am more than happy to pause right there and then and give answers to the questions to make this as much as we can, as interactive as we can.
Great.
Fantastic. So I am not sure how much of familiarity we already have with ISTDP out of the audience. Usually what I do if I'm running a workshop or a talk like this, I try to tailor it for the audience, depending on how much pre-exposure you have had to the model. Is it possible in any way for you guys to let me know whether you're all ISTDP practitioners, you're fairly familiar with the model, or some of you are for the first time attending? Can we have any assessment on that at the moment? Have most of you have had some trainings before? You can just type, I'll have a look. Very familiar, practitioner, familiar, very familiar. Okay, fantastic. Everyone practices. Okay, excellent. So this helps me. Excellent. Thank you. This helps me to know I'm not going to spend too much time on the theory. Some of you guys are clearly experts, which is fantastic to know. Kindly put the microphones, everyone's microphones off on mute. That would be great. Thank you for that. Okay, so I will then straight get into the talk. Let me just be able to. All right. So before I start getting to the research, this is the format of what I'm going to talk about this presentation today. I'll first speak about my personal and research background, theory of ISTDP and research outcome, rationale for the dissertation, why should we understand mechanisms of change of ISTDP. I'll present 3 different studies that all together comprise my PhD, and I will have a brief conclusion and an open discussion. First, I want to say a little bit about myself, how I ended up doing ISTDP. I am originally from Iran. I grew up there and did my undergraduate studies there. The first time when I saw an ISTDP video was in 2004. A lovely practitioner by the name of Dr. Javad Nafisi. He was visiting Iran, and I saw the first videos of ISTDP, and I was so touched by it and so influenced by it. I thought I really should learn this model. It looks amazing. I moved to Australia in 2006, and after finishing my postgrad studies in 2008 and 9, after 3-4 years, I started my own training and practice in ISTDP around 2011-12. My first initial idea was to do a randomized controlled trial on ISTDP as opposed to process research, but something along the way changed my mind. I'll explain to you why. Please give me 1 minute here. I'm going to divert from the main conversation. I'm not going to take long here, but there is some topic that is very important right now. It will take less than 1 minute. As I have mentioned, I'm from Iran, and if any of you are following the news these days, would be aware of what is happening in Iran. I'm not an activist, and I'm not asking you to be one. But I think ultimately as psychotherapists, our goal is to care for human beings and care for human suffering. Unfortunately, the situation in Iran at the moment is not in any way good. Women do not have the same equal rights as men do. A lot of times when we are within the framework or within the structure of psychotherapy, we are obliging, we're following certain principle of equality between every single human being. Whilst that is not necessarily carried out around the world, and as an Iranian person who has migrated to Australia and lived here, I have noticed very important clinical implications for those of us who have been raised in environments where people are not treated the same and are not treated equally. Very interestingly, we might form defenses collectively that explain our history. So long story short is, I do encourage you to be aware of the struggle of Iranian women and all people in Iran. And I just wanted to invite and bring your attention to this very important issue. I'm not going to take any more time other than highlighting the very real struggle that people are experiencing. Back to the research. Davonde was also from Iran, and he developed the study, the method of ISTDP at McGill University in the 1960s. The attempts were originally to make psychoanalysis more effective and more efficient. The technique has evolved and had been modified over the decades, and it's the most well-studied out of the all of the short-term dynamic psychotherapy models. There is a question, or there's this principle that we all know that psychotherapy in general is effective, but there's a very important question of why is psychotherapy effective? This has led to a great psychotherapy debate between the common factors and specific factors in psychotherapy, and the process of the dodo effect, where we say every single therapy has proven to be somewhat effective in its own way, which has led to the question of then why should we study specific models of therapy if every single therapy is almost equally effective? This takes me to Wampol's contextual model of change, in which he speaks of 3 major methods that we bring about change in psychotherapy in general. There are like 3 pathways in the contextual model, and every model of psychotherapy can be seen as making change through one of these paths. One is through the real relationship. Wampol argues that as human beings, we are ultra-social creatures, and we thrive on connection with others. And within the environment of therapy, there's also a real relationship between 2 human beings, and the quality of that relationship has been throughout all the research shows that is one of the most important factors in therapy. So therapy is effective. The second one is that when we enter therapy, we often enter it with the conceptualization of our problems. Every single patient that walks into our office has an understanding of why he or she is suffering. Then, depending on the model of work, we provide an alternative explanation for why they're suffering. And the degree to which the patient agree with our conceptualization becomes an important second pathway of change. This covers placebo, but is not limited to placebo. So we always reconceptualize the patient's problems, and then we suggest a therapeutic task and a therapeutic action that if the person carries those, we expect to see some form of healthy action. This is the same in cognitive therapy, behavior therapy, psychodynamic therapy. It doesn't matter what model you're looking into. This has led to some people arguing that it's not important to understand what is the specific mechanisms of change of psychotherapy because all therapies are equal. I have argued in my research, and it's not only me that has mentioned this, that whilst all therapeutic models tend to use these common factors, not every therapeutic model will use the common factors equally. What I mean by that is that we can argue that certain therapeutic models might be more effective in using the common factors to bring about change. And this is what has convinced me to carry out this research. What I mean by that is some therapies might be more effective in using the relationship, improving the relationship, creating expectations or conceptualizations, and a therapeutic task that might be more effective than other models. So it's important to understand why we bring about change and how we bring about change if we want to show the actual effectiveness of a therapeutic model. So this was the rationale for my study. I will really skim through this stuff. These are previous research that has been done on effectiveness of ISTDP. This is now around 10 years old. It's a meta-analysis, 21 published studies, 10 controlled and 10 without a control group. And we can see that in general, they had a large sustained effect sizes, and 8 studies had shown cost effectiveness. So the general argument is that ISTDP is an effective model of treatment. And what is very interesting is that it's shown to be effective with certain type of disorders that we don't typically see therapies to be effective with. That includes personality disorders and psychosomatic disorders. These are typically not easy therapeutic models to treat. And it's very interesting that ISTDP has shown and proven to be effective within these models, which was another reason to intrigue my trigger my interest in trying to understand why is ISTDP effective. I'll very quickly go through the theory of ISTDP. At the center of the theory of ISTDP, although Davandu may have not directly spoken of it himself, it's the attachment theory, that there is an innate tendency for bonding with others. There's tons of research by Bowlby, and I don't need to introduce attachment to you guys. You're all accomplished practitioners, and we know that attachment theory has been proven in many different fields of science. In ISTDP, we look at attachment trauma or pain to the connection, pain that is caused due to the trauma, activating feelings of rage towards the attachment figures and guilt about the rage that sits underneath that. The activation of the rage and unconscious guilt that is not consciously processed leads to development of strategies that maintain attachment but sacrifice the individual's authenticity and authentic experience of self. And at the forefront of the work, we start to see the psychological symptoms that are the result of this internal conflict between the authentic expression of self and anxiety and defenses that have developed to keep these feelings or push them out of the conscious awareness. Again, feelings are activated, and feelings that are not acceptable within the structure of attachment connections with others trigger unconscious anxiety, and we might develop defenses that are designed, or they tend to ward off the anxiety and feelings that have been deemed unacceptable. This pattern is very consistent across our connections, whether it's within the transference, with current figures, or with past attachment figures. So we use the triangle of person and triangle of conflict to conceptualize patient suffering. I really like this slide by Alan Abbas, in which he has summarized the pathway of change in psychotherapy and in ISTDP. I'm not going to go through it as we have to be efficient with time. So there are certain principles in ISTDP. The experience of unconscious feelings is considered therapeutic. Resistance, including anxiety, is the main barrier against experiences of these feelings. Insight into these feelings, our conscious awareness of our feelings, the associated anxiety, and the defenses within the context of attachment relationships, the whole experience of insight is deemed to be therapeutic and lead to positive therapeutic changes. Unlocking of the unconscious is a key therapeutic process, and guilt is central to psychopathology and formation of resistance. The aims of my research were to increase our understanding of mechanisms of ISTDP, and I have 3 separate studies that work in tandem with one another to be able to increase our understanding. The first thing that I thought when I thought about how to do this research was to first figure out what has already been done. So I thought it's important to do first a systematized review of mechanisms of change in ISTDP. First, I need to know what has already been done. What are the research stuff that has been done to explain to us why is ISTDP effective? And then try to identify the gaps in the literature. And then in my second and third studies to try to contribute to filling those gaps. So in the first study, which was published in American Journal of Psychotherapy with my lovely colleagues in 2020, we tried to critically evaluate the emerging literature and explore directions for future research. In a systematized review in the main online databases, I searched the word intensive short-term dynamic psychotherapy, ISTDP, DABANLU, and the second search of mechanisms of change mechanism and unlocking. The titles and abstracts for potential relevance were assessed, and inclusion criteria were English, peer-reviewed, or unpublished dissertation. ISTDP was the primary treatment. It had to be empirical format with data, and explored mechanisms of change of ISTDP. So this meant that if, there have been a lot of excellent books and articles written on mechanisms of change of ISTDP. After publishing this, some people got in contact with me and said, hey, why did you not include some of the work of of great thinkers in ISTDP? And I had to explain that, I followed a very strict inclusion and exclusion criteria, and I had to submit this for journals that have very kind of specific word count. So this is not in any way to undermine the work that has already been done by others in the field. This, I was just following this this very specific criteria. There were 358 studies initially, 38 papers met the criteria, they were full reviewed, and 14 were in the inclusion for the paper. I categorized this into 3 major groups. 4 of them have specifically explored unlocking. 6 of them have examined the pattern of interaction between the patient and the therapist. For example, looking at the sequence of what intervention has the therapist done, and as a result, whether what has been the result in the patient, whether they have felt emotions, whether anxiety has increased. So has explored the pattern of interaction, the sequence between the patient and the therapist. And there were 4 others that have explored others areas of mechanisms of change in ISTDP. The findings reveal that in general, we need more research in more kind of peer-reviewed studies on understanding mechanisms of change. The findings also revealed that unlocking may be associated with positive therapeutic changes. In 4 of these studies, when unlocking had taken place, we have seen improvement in the patients that had experienced unlocking. One of the major shortcomings in the literature was that there was no operational definition of unlocking. In studies where unlocking was explored, in all of those studies, an expert clinician has determined whether unlocking had taken place or not. So I thought if I could come up with a strategy to find, or at least take a step towards operationally defining unlocking, that could be a contribution to ISTDP. And we also identified 2 distinct patterns of change: unlocking and also changes in the resistance. What I mean by that is that some of the research pointed out to the fact that in some patients that had received treatment with ISTDP, we have seen major improvements in their symptoms without those patients experiencing any unlockings. And that was something that was very interesting and intriguing, because as many of you might be able to relate, in my early years of learning ISTDP, I was all about unlocking, at least in my own mind as a practitioner. I always thought, if I don't get an unlocking, there's no worth in what I'm doing. And that, of course, didn't lead to good outcome for my patients or myself as a therapist. So I think this was an interesting finding and something that I'm going to talk about a little bit more. In the second study, which was published in American Journal of Psychotherapy as well, very recently, 25th of August, what we tried to do was to try to use ATOS. I'm not sure how many of you are familiar with ATOS. It's an theoretical process-based measure that was developed by Lee McAuliffe. An excellent tool in which you can measure core concepts of the theoretical model that you're using. It was originally made for affect phobia therapy, but it was the closest measure that I found that looked like the concepts and the theory are close to the concepts of ISTDP. For the study, we adopted a detailed process analysis of the early phase of therapy. It was a naturalistic study of 4 cases. And we tried to see whether we can find a way to operationalize unlocking. The other goal that we pursued here was to see whether raters and people who are trained in ISTDP, whether they have high inter-rater reliability in identifying the episodes of unlocking. So 4 different raters, two initial raters, a third rater that was added to the team later, and also the therapist for this research. All of us watched all these videos and identified whether in any session we identified unlocking, and if unlocking took place, at what point in the session within the 10-minute segments did unlocking take place. A little bit explanation of ATOS. ATOS has 7 major subscales. We used 4 of these subscales for this research. The subscales are insight, motivation, exposure to feeling, inhibitory emotions, new learning, sense of self, and sense of others. I did not include numbers 7, 6, and 5 in this study, and we looked into the other 4 concepts. And when I went through the scoring guidelines of ATOS, based on the guidelines that they provided, we came with these clinical cutoffs. And it was quite a, I'm really interested to hear of your opinion and what you think about this. What we tried to think was, I'll use one example. For example, in motivation, if you would score less than 50 in motivation on the subscale of ATOS, let's say you score 40, it means you're still in an ambivalent state about letting go of your defenses. So I came to think to myself, if you're still ambivalent about letting go of the defenses, you're very unlikely to experience an unlocking. So your score on motivation has to be 50. And with this type of logic, we started to rule out and think, okay, what are the numbers that, based on our theoretical understanding of ISTDP and unlocking, in what way would they correspond with the subscales of ATOS, and came with these 4 clinical cutoffs. And we said, okay, if you have an unlocking, you need to have these 4 criteria: that exposure has to be 50 or above, insight has to be 50 or above, motivation has to be 50 or above, and inhibition has to be less than 50. In addition to these 4 things, on the ATOS measure, you have to rate on the exposure subscale, number 3, you have to identify what is the adaptive emotion for this patient in this 10-minute segment. You define the session into 10-minute segments. And we thought to ourselves, if there is an unlocking, you have to think of, and you can rate different affects for exposure. So you can rate, let's say, anger, and if grief is also relevant, you can identify grief as well. In case of unlocking, we thought it has to be rage, and it also has to have element of love or care or guilt about the rage. So we start to look and see in what 10-minute episodes did the raters rate 2 different affects at the same time, both the rage and guilt about the rage, and care or kind of positive emotions. And that as the 5th criteria for the study. So this was the profile cutoffs, raters identified them, and the sessions were rated with ATOS. For inclusion and exclusion criteria, participants first with the clinical interviews, SCID 1 and SCID 2. And these were inclusion and exclusion criteria based on Alan Abbas's 2008 study with personality disorders. I tried to use similar inclusion and exclusion criteria. All right, I'll go a little bit faster, guys, to make sure I'll get to the end of the work. So the therapist had 15 years of experience. They were independent raters. We made sure we get the study as strong as we possibly can. And out of the 11, we identified 11 instances of unlocking. It's worthy to note that all these 11 took place with 1 patient. So out of the 4 patients, 3 of them in the first 10 sessions did not experience unlocking. It was only 1 of the patients who did, which is one of the limitations and one of the weaknesses of the study. In this patient who experienced 11 unlockings, 8 of them met all 5 criteria, and 3 of them met, 2 of them met 4 out of 5 criteria that we have identified, which we were thrilled to find out. It was very exciting. And of course, there's still more work to be done, but this was a very positive result for what we had aimed for. We also identified that it was very high inter-rater reliability between the 2 raters, between the 3 raters and the therapist, which was again very encouraging to think, those of us who are trained in ISTDP, it appears based on the data that we have so far, there's high level of inter-rater reliability between ISTDP therapists based on the findings of our study. After the first 2 studies, in the 3rd study, I tried to dive a little bit deeper into the process of change within the first 10 sessions of therapy. What I mean by that, I tried to tell the story of these patients. How did with what presenting problems did they come into the session? What took place between the patient and the therapist? And I gathered a host of qualitative and quantitative data to be able to look at the pattern of interaction between the patient and the therapist from multiple angles. So I interviewed the therapist, I interviewed each of the patients. We did WAI after each session, monitoring for therapeutic alliance, and went through the whole script of the 30-40 hours of therapy and highlighted important patterns of interaction
between the patient. So this is between the patient and therapy. So this one is more kind of in-depth analysis of the process of change. Just waiting for this slide to come. All right, and the majority of these patients had some level of fragility, with the exception of one of them that was only very mildly fragile. These are the assessment tools that we used. The presenting problems, anxiety disorder, based on the DSM, was anxiety disorder not otherwise specified, major depressive disorder, one person with agoraphobia and generalized anxiety disorder, and a person with borderline personality disorder. This is the story of each of them and the kind of general background information. I'm not going to go into details of all the 4 cases, would be beyond what we will be able to cover in this case. But it was interesting. You know, the first patient was the patient who had experienced all the unlockings in the previous study. And the findings of our study was that she made excellent progress after 10 sessions of therapy, did not meet criteria for any mental health disorders in the follow-up interview that we did. She was super happy with therapy, and when I interviewed her and asked about what were the elements that brought about changes, she described that she, for the first time in her life, started to understand why she did the behavior that she did. She was very amazed how the habits that she was unconsciously doing now were deeply related to her experiences of when she was a child and how she had been abused and things like that, which was for her, the insight and becoming aware of the previous emotions was very, very crucial. The second case, the gentleman who presented, if I go to the next slide, you will see the defenses of each of them. With a very severe case of punitive superego. So this patient did not experience any unlockings. A lot of the work was about working with the forefront of the resistance, which was the PSE. And it was very interesting because, again, interviewing this man, he had noticed a lot of positive changes in his life without ever experiencing an unlocking. Now, I have to say that the therapist for this study was a very experienced therapist who was very good at what he did. And for me was very interesting how this patient, you know, after many years, he was working a lot more, motivation has improved. It was a lot of change in sense of self, in how he perceived himself. And that was, again, within the first 10 minutes. There were improvements in some of the subscales for this man on I'm trying to recall on BSI, brief symptom inventory. Patient number 3 is the patient who dropped out of therapy. Only for 6 sessions he attended, and it was very. I have kind of explored the reasons behind the dropout. It appeared to some extent that some of the syntonic defenses had not been addressed adequately. Again, this has been discussed in details in my paper. I'm not going to go into it right now. And patient number 4, it was a case of a very severely fragile patient. It was very interesting that 4 hours of therapy led to major improvements on BSI and IIP with 6 months follow-up. So this was only 4 hours of work because the patient couldn't afford anymore. And within those 4 hours, the patient made massive progress, like such a massive hike in improvement of his symptoms, and a lot of significant changes that he had noticed for the first time. Again, understanding more about his anxiety, understanding the things that is taking place inside him. They all mentioned how understanding was an important part of the process of change. Overall, results indicated that the graded format of ISTDP was associated with treatment improvements. One patient with only 4 hours of treatment experienced partial recovery in spite of decades of problems. 3 of 4 patients reported improvement in terms of general psychological functioning, interpersonal functioning, and mental health symptoms. All 3 patients demonstrated reliable change. The results suggest that even when treatment is short and does not include unlocking, ISTDP can be beneficial. Results also provide support for the use of the graded format with patients who have higher levels of fragility. In the dissertation, in this PhD, the aim was to increase our understanding of mechanisms of change of ISTDP. First, I did a systematized review and tried to identify the shortcomings in the literature. In the second study, I tried to take a small step towards operationalizing, in a pilot study, operationalizing the concept of unlocking. And in the third study, we tried to do more in-depth qualitative case review of 4 cases that had received ISTDP with different levels of fragility. Thank you very much for listening, and I look forward to hearing your questions.
Thank you so much.
Thank you.
So, if nobody seems to be going for it at this moment, so I have a question. Can we just shut down the, yeah, that's right.
All right, this is better.
Great. So thank you very much for this presentation. I found myself thinking about this definition of unlocking that you're suggesting, using the ATOS and using these 4 different criteria. And also reflecting on the results from the last study then, that you see all these improvements without unlockings according to your criteria. I was just thinking about maybe that your definition of unlocking, the requirement of so high affect exposure, if this excludes the fragile group, because they will never tolerate a proper unlocking in that sense. But I think with the fragile group, what you will find is that when you do the work, that they have huge insights, and the unconscious therapeutic alliance will, of course, start moving when the work is going well. And this, to me, seems to be also a form of unlocking, even though the affect expression in session might be more subtle or more shy. It would still, in my view, as an ISTDP teacher, I would still say, yeah, this to me is an unlocking, even though the patient is very calm and there's not much feeling breaking through. Can you say something about this? What do you think?
Oh, absolutely, Thomas. Like I agree with everything that you say there, and it's one of those. I would love to hear your opinion, and maybe later on you and I can have conversations about this to see, because we're looking at 5 different criteria. I think what's very therefore, like, you know, 5 criteria we're looking for. I think the goal has to be to raise the bar low enough to be inclusive of patients who are having even minute levels of affective expression or kind of affective experience in the session, because as you're correctly pointing out, is that, you know, unlocking doesn't look the same for different patients depending on the level of fragility or level of resistance that they're manifesting. So it has to be a way, in my opinion, that it covers all this, but it's not limited to that. So I think there's a case to be made, and I think I'm gonna, because as I said, this is a pilot study, and I think there's a lot of room for improvement. And I think one of the very interesting conversations to be held is what would be more precise number to use with higher level of population to be inclusive of patients that may present with different models of unlocking. So I think you are onto something here. I absolutely agree with you. The difficulty here is that we're using a measure that was made for affect phobia therapy, and then we're trying to translate it into ISTDP models. For example, another problem that I want to highlight, Thomas, is that affect phobia therapy doesn't measure emotion of guilt as a primary adaptive emotion. So it looks into other emotions, but it doesn't have that criteria. So some level of adjustment needs to take place, but we needed to start somewhere. Yeah, you know, the goal was here. My aim wasn't to solve the problem, was just to kind of take a tiny step towards it. But I agree with your observation. It's a very good point you're raising.
Yeah, thank you. I mean, this is a great contribution. I'm just thinking, well, to me, it's not satisfying because I have all these fragile patients and they wouldn't fulfill these criteria, but still, I would say they experience unlockings.
Yes. No, it's true. And maybe later I'll send you the scoring of ATOS, and then you let me know out of those cutoffs, what number would you suggest? No, I'm serious. Like, what number would you suggest that you would think would be best to be inclusive of the fragiles? Because, you know, I think this is the way to push this forward. You know, we gotta talk about this. You know,
I mean, I can just briefly respond that. To me, I think that, and this is a point raised by the Danish therapist Mikkel Langberg, I think he's in the audience as well, that maybe thinking about ISTDP as an affect-focused therapy is a bit of a problem, because it's so much about, on the one hand, resistance, and on the other hand, insight. And I think that if you try to define an unlocking, there needs to be some idea about the freshness of the new material that comes up, the insights where the present is linked to the past. And I don't know if this is captured by the ATOS, this ETA aspect of,
So ATOS, well, it's not perfectly captured, but ATOS is the closest we got. For example, in the subscale of insight,
right?
If the patient themselves make a link between the present and past experience, they would get a different score than if the therapist suggests it. So you know, to do unlocking, we need 4 criteria. We need the defenses or resistance shouldn't be highly activated. We have that on inhibition, so we can measure that. Insight is another thing that you can actually measure it with ATOS, which, you know, it's not perfect, but it gets us a step towards it. So this is a conversation to be held, and I think it's I think late Lee McAuliffe, she had done a great job in finding a measure that potentially can be used here. So it's not just affect, just to let you know, it's affect. So it's exposure, it's inhibition, which shows affects like shame, like resistance, self-attack, all of those things. You can look at it in inhibition. Motivation can be defense awareness and willingness to let go of defenses. So motivation is close to willingness to let go of defenses, and insight is capacity to see defenses. So they are fairly close to ISTDP concepts, and we looked into all of those 4.
Yeah, thank you for clarifying that. Thank you.
No.
So we have a raised hand, Sarah Walker.
Hi, Paige.
Hi, Sarah. I'm in your office.
Yeah, patients in my office. Because I'm at home with COVID. I got COVID at the Venice conference, but it was really great being there. It was worth it. So, Pejman, thanks. That was really interesting. And it's done the best thing about research. It's raised even more questions. So you've succeeded. Bravo. But I was thinking, you know, when Thomas was talking about the population group and the psychoneurotic and then the fragile population as well. And as you know, the people I work with are always moderate to severe fragility. And so my definition of unlocking for them is almost the unlocking of grief about how their defense or their superego, their punitive, their self-harm, their self-destructive aggression towards themselves has impacted on them. And probably what I see is that has a huge therapeutic change if I can restructure those defenses and allow them to see the cost and that grief and the guilt around the way they've treated themselves and attributed all the blame on themselves. That's kind of my definition of an unlocking. and which is going to be different to the psychoneurotic population.
Yes.
So, yeah, I think it's a terrific discussion, and you've done the best thing. Like you know, I said, research brings more research and more questions, and that's always a sign of good research.
Yes. Sarah, just to clarify, like for the purpose of our research, we were looking to the closest definition that Abbas and Town have given in their 2013 paper. Does unlocking the unconscious makes a difference? And they were looking into major unlocking. And they were, so, you know, what you talk about with fragile population, one might make reference to it as first breakthrough, or breakthrough about, or grief about defenses, or, you know, so there's so many elements in ISTDP, and that's one of the arguments to be made, that are really therapeutic, and at least by some classic definition are not unlocking. So I think this is the case that wanted to be exactly as you're saying. And with fragile populations, as you and Thomas pointed out earlier, it looks more complex. It looks more subtle. It looks more, you know, you go from the first breakthrough into an unlocking without really knowing how it happened. So I think it gets more complex as the patient presentations gets more complex. And, you know, good luck being able to measure those things, but we got to try somewhere, you know.
No idea how to measure it. That wasn't my that wasn't what I was saying.
Very good point again. I agree. I think you and Thomas are pointing out to the same thing, which is lovely to hear. Yeah, I agree.
I'll be back next week, by the way, as long as I'm okay.
Get well soon.
Yeah.
Thank you, Sarah. Are there any comments or any questions? I can see a comment here. Wouldn't it be more realistic to identify at least two patterns of outcome? One for psychoneurotic patients and one for the, oh, wow, that is very interesting. Yes, it could be Alan. I think this comment is from, this commenter is from Alan. I think it eventually might lead to that pathway. Because you know, it looks like that it could look different between these two patients. I just want to give a reminder that when Davonlu originally developed ISTDP, it wasn't even inclusive of fragile patients. Like it, and he, as his skills developed and the theory developed, it got more and more applicable to the broader population. So I think it's only natural for the measurement and operationalization of the concept to follow the same path. We start with more straightforward, vertical ways of approaching, of measuring the unlockings, and then as we make the progress, hopefully going to be better ways and strategies to look at it. But I think it's a very good point to be raised there. There's another question of how high was the inter-rater reliability. Let me have an exact look. It was 0.9. I don't remember the details of how much. It was very high. It was 0.9. There are only 11 cases. So you can see that it's not because of the very small sample size. The inter-rater reliability can be very high, but yeah, it was very high, 0.9 something. And that is between, you know, 4 different raters, which was very cool. And this would be very interesting for any of you who is interested to do ISTDP. And if you want to, I think, you know, this one is probably a very much straightforward one of recording the sessions and then asking your colleagues to watch it. And did they see an unlocking in the session? And, you know, and then comparing with one another, seeing whether we all see the same thing as they take place. You know, these are interesting things, fairly easy to measure, and it adds to the you know, validity of what we're doing here. I can see, yes, Nicholas, if I say
thank you so much. It was very interesting. Would you comment some on future directions for research of this type? Like, I mean, given that ethos is the best thing we have at the moment to look into these things. Like, what do you think is important to investigate in the future when it comes to ISTDP processes?
Yeah, thank you, Niklas. How I see it, and I think what would be kind of the next steps from the next logical steps from here after I, after I get a little bit better from this feeling of burnout that I have right now about research, that I'm kind of done with it all. But I think as soon as I get a kind of second breath, I think what I think would be very useful to do from here is, I think, some collaboration with some ISTDP and ATOS experts, kind of sitting around table, having conversations to see what would be, in what ways can we modify the measure to theoretically make it suitable and adjustable to ISTDP, because there's some theoretical differences and they are quite significant. There are important theoretical differences. And I think we've got to look into people who are really good at both of them. Or, I had I'm very grateful for Christine Osborne, who helped me with supervision and training of ATOS when I was getting myself trained to be able to do some of the ratings. And I've had, like many of you, the privilege of getting supervision and training from some of the some of the experts in the field, which definitely helps. But I think it would be nice to bring these two worlds a little bit together theoretically, and try to see first what suggestions they have, because I learned a lot of this on the job, like as I was doing it and the years were passing, I'm like, oh, but then ATOS doesn't do this. And it was a lot of learning as I was going with it. So I think now that this has finished, would be nice to regroup, have a bit of theoretical discussion, and then do the same study, arguably, on the study that Abbas and Town did in 2013 and used clinical judgment. This time, let's use this method that we came up with. So we just do the same thing with ATOS trained people and compare our method with the clinical judgment. This is the next logical step that I have in mind to add to this after I feel like I feel a bit more normal.
Yeah,
Thank you
that
so
sounds
much.
very exciting.
So I think we should come to an end here to let people go back to work over here in Europe. I just want to say a huge thank you, Pejman. This work is a great gift to the ISTDP community worldwide, and other people will grow from it a lot. And I'm certainly hoping that more of us will take this step to do more research and try to really understand what's going on when we're meeting patients. Thank you so much for showing up and giving us this. Do you want to say something just to get to an ending?
Sure. Thank you very much for making this happen, Thomas. Thank you for everyone who participated here, for putting up with my accent and with the, with the kind of clumsiness of going around and trying to kind of manage. I'm not exactly a technology geek type of person. So thank you very much. I really appreciate you guys attending and listening. It has been a pleasure.
Thank you so much. And thank you to all of the audience too. Yeah.
Thank you.